everyone. Thanks for joining us for this episode of Pursuing Quality Long-Term Care, an educational podcast for individuals needing long-term care and their families. I'm Jocelyn Bogdan, Program and Policy Specialist at the National Consumer Voice for Quality Long-Term Care. Today's conversation, when your loved one is labeled a bad fit, how to advocate for the quality care you deserve, will begin with a story from a family member, Kathy, who worked hard to advocate for her mother as she was placed on medication and transferred between facilities. Then we'll bring in Tony Chicotel from California Advocates for Nursing Home Reform to discuss what residents and their families who find themselves in similar situations should know and do, and how they can advocate for the care they or their loved ones deserve. But first, here are some clips from our discussion with Kathy, speaking about the experience her mother endured and how it felt for her to navigate the process.
Her biggest behavior was that she would yell. She would yell out when she was excited, when she was, she was very much like a yeller and a clapper. And I remember the last facility that she went to before she went to a place that was specifically for individuals with different behaviors. It was just really, she just told me my mom wasn't a good fit. And,
Right.
I'd heard that a couple of times. Your mom's she's not a good fit. And it's really painful to hear that because my mother wasn't mean or aggressive. She wasn't violent. She yelled a lot. And I don't even know what that means. You're not a good fit, to hear that. And I remember the last place that she went to before she went to another facility closer to my home. It was just so mean. And it was like, she can't stay here. She needs to leave. And of course they make the calls on a Friday. So that was, I remember, I think I was actually on a work trip a couple hours out of Phoenix. And so to get a call around lunchtime, like, your mom's just not a good fit. And I just remember saying, like, you need to help me find a place that will be a good fit, because this is like my third time doing this and I need help. And if you're going to evict her, help me find a place that is going to support her and support me and help me. And at the end of the day, I think she did find a place that was, geared toward individuals with behaviors. It was considerably closer to my home because the last place my mother was at, she went there after a stay at a geriatric psych facility. And so literally no one would take my mom. Like, they look at her charts and they try and find a facility that will take them after 30 days and after being stabilized and on various different drugs. And this was the only one that would take her. And it was like, on a good day with no traffic, roughly 20 minutes from my house. So it made daily visits difficult. And I was told that she would probably need to go to a geriatric psych ward to be stabilized. And that's this word, stabilize. I heard that so many times in my experience. They need to be stable. They need to be stabilized, or no one will take her. And that's, I think, and I consented to it. I said, because I was just feeling like pushed into this corner of what do I do? What do I do? And so, because there was always this looming threat of being evicted. We just did everything wrong. I did everything wrong. I think you don't know what you don't know. And so you kind of have this expectation of what people, how these facilities are going to operate. Mm-hmm. And it was a very steep learning curve. And, it was difficult. And I don't remember the exact medication that she was on, but it was a lot. And I remember she was kind of getting more and more groggy and just less talkative. I mean, I have video of her in the beginning and she was considerably more animated and talkative. And then over a period of, I don't remember how long, she just seemed, I don't know if they changed the medication and didn't tell me, but she just seemed to get more out. Like, she got to a point where she seemed really out of it. And I kept asking, like, why can't they change it? And that was really hard because it's like I could never get a meeting with the psychiatric nurse who would come in and manage everyone's pain medication. And they were like, oh, she was just here. And I'm like, well, can you have her call me? And she would there was all of this cross wiring, like we could never connect. And I'm like, can you please have her call me when she's there? Because I want to talk about this with and I could never get in contact with her. So I remember that distinctly. Honestly, I mean, I just thought, I never pushed back too much on earlier in the process because the psychotropic drugs, everyone kept saying like, well, she'll get kicked out. She needs, we've got to stabilize her. If she's not stable, we can't have her. We can't, you can't have somebody who's screaming everywhere. So I didn't really even know how much I could push back on. There was so
Right.
much I just didn't know. I just felt like, honestly, I kept running into a brick wall all the time. I kept like I was just, heaving this boulder up this mountain when it came to my mom, and it would just come crashing down over me. And that's what it felt like all for several years of just pushing this boulder up, and then it would come back down on me to the point where, I remember when I was just reading my blog that I used to chronicle this at the time. And I was reading about when she was at the second geriatric psych ward. And I should say the first geriatric psych ward, they wanted to do electric shock therapy. The doctor thought my mother was bipolar in her 70s, which I'm not a doctor, but even I knew that that was absurd. And my dad actually ended up taking her out against medical advice, which I think was the right choice. But I think it's so ingrained in us that, if a doctor says X, we comply. And I think in this space, family members should be more empowered to feel comfortable to push back and to ask questions. But I think they need that resource for that language. And that's something that I've seen just in the work that I've done since. Family members don't feel comfortable pushing back because they're not necessarily the experts, but they are experts. They know their loved one. I would have kept her home maybe, or tried to, or at the very least, I would have fought harder and pushed harder. I think that's a big thing, because I felt like, I think as somebody who's a rule follower in general in life,
Mm-hmm.
which I feel like I listened to people and I believed them, and, kind of nodded my head and said, okay, well, they know best. And maybe they're right. And I think that was the wrong thing to do. And I think there's a way to push back, but I think there needs to be language that helps caregivers know what they can say and what their rights are. Like, I didn't even know that I had rights or that my mother had rights. I didn't even realize, like, I could have said, stop it now. Take her off the drugs now. Because when I asked about that, it was not like, that was not a suggestion that was made. Like, you can just say, stop.
Right.
So, and I learned from you that I could have 7 years later.
So we just listened to Kathy's story, which I know was painful and hard for her to share. We're so grateful that she was willing to share her experiences with us. What she went through was unique to her and her mother and her family, but we know that what her mother experienced in her facilities was not unique at all. Her mom was told that she wasn't a good fit for her facility. She was put on antipsychotic medications, and her family, who were acting on her behalf at this point, weren't clear on what medication she was being given or when. They weren't sure what would happen if they tried to push back. Kathy's mom was sent to a psych ward, and her family was concerned about whether or not they'd be able to find a new facility for her. And throughout this, Kathy wasn't sure what her mother's rights were, or what she could do, or how much she could push back as her mom's representative. This type of experience is awful, but it's one that many long-term care consumers face, and one that many families work to navigate. Because of how prevalent some of what Kathy shared with us is, we wanted to bring in Tony Chicotel from California Advocates for Nursing Home Reform to have a conversation with us about Kathy's experience and what families who find themselves in similar situations can and should do. Thanks for joining us, Tony.
Oh, I'm glad to be here. Thanks for inviting me.
Sure. The first thing I wanted to ask you about, and then maybe you can walk us through what you would tell a family that raised these concerns, what they should do. One thing that really jumped out in Kathy's experience was that the facility repeatedly said that Kathy's mother wasn't a good fit. They heard this over and over. And Kathy did describe her mother as a yeller and a clapper. So maybe there were times when she acted in a way that wasn't convenient for the facility. But, as we know, facilities should never just write off a resident as a bad fit or say that they don't belong. And so I'm wondering what someone should do in Kathy's situation if this is what they're told. Let's say they're a resident representative, they're making the decisions for their loved one. But I also want us to talk about what the facility should be doing. Let's say there's a patient who's yelling at night or disturbing other residents. What's their obligation in that situation?
Well, let's start with the second part of what you were getting at, which is what should the facility be doing? And I think this is important foundationally for just family advocacy down the road is to know what good care is, what good care looks like, and what it feels like. And essentially for dementia care, good care is creative and patient and exploratory. It is care that's provided with love. And I know that that's might make people a little bit uncomfortable to think about institutional settings, care settings as places where the staff should love the residents, but they should. And if they don't actually love the residents, they should provide care as if they do, or as if they would want someone to care for their family members. So, every resident needs different things. But of course, there's a whole lot of overlap. But every facility should start with that premise that our residents have needs and we're here to fulfill them. And if we can't figure out how to fill those needs the first go round, we should continue to try other things. And that's where I mean by being sort of creative and patient and
Right.
Adaptive and all those kinds of things. So what does good care look like? Good care looks like a place where the residents are happy, where they're comfortable. And I know Kathy got into a little bit about her mother yelling and clapping. Yelling and clapping are natural. I mean, that's what human beings do when they reach a certain emotional state. So the job of the caregiver, and they should welcome this. They should be happy that Kathy's mother was expressing herself in this way so that they could learn what Kathy's needs were better and how to fill her needs so that she wouldn't reach that emotional state, which was probably she was expressing some level of discomfort or being upset about something. So then the idea is, okay, she's told us she's upset. No, what might it be that's upsetting her? Is it the fact that she's hungry, or she needs to go to the bathroom, or she's in pain? I mean, those are the obvious things that you think about. But then there's other things that are less obvious. And this is where the caregiver, as someone who loves the care recipients, comes in. Is it something like she just needs to be reassured? She needs some basic human contact. She may be in a place with dozens of other residents and dozens of staff members day in and day out, but are they actually paying any attention to her and making her feel like she's valued and that she's an important part of other people's lives? That's what people need, and this is just sort of natural. So that's what, to me, what good care looks like, something like that. And then the second part is, what do you do when a facility seems unable to provide the care that I've described? And this is tricky. I think this is really tricky. And every person, it's going to be very, very fact intense. But and on one hand, you want to say, okay, they're not, this facility doesn't get it. They're calling my mom. They're saying she's not a good fit. And that just, to me, indicates that this is a place that's full of caregivers who don't really care. It has a bad culture, and maybe they're doing me a favor by warning me that they're not a good place for my mom, and I just move her somewhere else. That's one side of things. Then the other side is, there's an opportunity here, and an opportunity to learn together, to collaborate with the facility, learning on what kind of care best suits my mother's needs, and for me to maybe raise the level of care that's provided throughout the facility for other residents, to change the culture, to sort of dig in. And I know it's a delicate balance, and I think it's going to line up for different people in different ways, but I would tend to encourage people to try the stick it out method, at least at the beginning. And that there's a couple reasons why. One, you avoid a transfer to another facility, and there's certainly no guarantees that the next facility is going to be any better, and there's a decent chance it may be worse. There's probably reasons why you selected the first facility in the first place. Second of all, the transfers can be very difficult, even if it is to a place that's equally good or even better. There's just a learning curve that can sometimes be traumatic for the resident. But the most important thing for me in terms of sticking it out is that I think you're going to learn a little bit more about the resident the family is going to learn more about the resident, the staff are going to learn more about the resident, and then there's this opportunity to improve care for lots of people in this facility going forward. And I think that's a chance to do some real good for lots of people that doesn't come around all that often.
Yeah, thanks. I mean, when you were talking sort of about the facility's obligations and the right to good quality care, it just struck me one thing we've talked a lot about in this pandemic that I think has been forgotten during COVID is that this is the residents' home. This is where they live. They deserve to be comfortable. They deserve to be, taken care of in the way that you're describing, because this is their home. So I appreciate you referencing that.
Can I build off that just for a
Yeah,
second? Because
sure.
this is a really important point that I want everybody to know. And this was definitely part of Kathy's story, and it's part of a lot of stories that I hear, which is residents and family members feeling under-equipped to be demanding.
Right.
Because for one reason, it's they feel inexpert, that they don't have the experience to know what the rules are and what good quality care looks like. And then second of all, they're just concerned that if they are at all confrontational with the staff and the administration,
Yes.
that there may be some sort of retaliation or things like that. Well, we can get into that, but what I want people to know first and foremost is that they should push back. They almost have an obligation to push back when they're responsible at some level for the care that a family member is receiving, where they've taken some ownership of that care. I think they have to push. And I think most people, deep down, they know what seems fair and what seems righteous. And if things just aren't adding up, the long story short is to feel comfortable pushing back. You don't have to be a jerk about it. You can be very polite. And I always tell people, when you're writing your letters or you're making your calls, start off with saying thank you. Thank you for agreeing to take care of my loved one. I know it can be tough, but we really appreciate it, and we want to be partners with you in
Right.
creating a care plan that works. But on the other side, we're going to hold you to your end of the bargain, which is to provide good quality of care, and we're going to make sure that you do that.
Yeah, I think that's right. And one thing that Kathy said that really struck with me that I wanted to come back to, or want to come back to a little bit later, is that, families don't feel like they're experts when they're dealing with doctors and nurses and people within these facilities who, you look to and think they have a lot more experience. But the reality is, as she pointed out, you're an expert on your loved one. You know more about them. And so when you do go into those care planning meetings, you can raise things. You might know that, your mother gets cold at night. Some of these fixes, if she's yelling out at night, might be as simple as giving her an extra blanket, but that's something that the facility might not know that you're aware of. So I thought, that was a really key point that she made. But to sort of flip a little bit, something else that she referenced was that, at one point, or at least one point, she wasn't sure what medication her mom was on, if it had been changed, if the dosage had been changed, and she was just unable to get an answer about her mother's medication from the facility. When she asked, she was told the person who prescribed and changed the dosages had just left or wasn't in, and she never got callbacks. She never got a straight answer. And, as you mentioned, in terms of pushing back, she said that she herself didn't push back earlier on the medication when she wasn't certain about it, because she was afraid if she did, her mom would be kicked out of her facility. And, we know that residents have rights surrounding all of this. First, as you mentioned earlier, they have the right to good care. They have the right to quality care. They also have the right to consent or not consent to medications. And they have the right to, and you described this a little bit already, like non-pharmacological interventions before medication. And they also need to have full documentation of the medications that they're given. So can you just speak a little bit to what a family should do if they're facing something like that? If the facility is just shutting them down when they're asking about medicine, and again, I think this is really important right now with COVID, because it's harder for family members to physically be in the facility and to physically be present. But it's a very big issue.
Yeah, the residents have the right to review their medical records, including the medication list and the medication administration record. And that right to review records usually applies to surrogate decision makers, like agents and a power of attorney,
Mm-hmm.
or family members who are signed the admission agreement, things like that. So that's a very well-established legal right to do that. And if a facility is denying that right or being avoiding the exercise of that right, what I recommend is, and this is what I recommend in lots of situations, is to reduce the demand to writing and make it clear that it is a demand. So you could say things like, again, thank you for being a care partner, and I'm glad to work with you. I have some concerns about medication. Beginning with the fact that I don't know what the medications are, and it's important for me to know this. So I would like to see the medical records. I brought this up a few times in the past, but you haven't provided any records or worked with me in getting them. So I'm putting my demand in writing, and I want to see the medical records within the next 7 or 10 days or something like that. If I don't hear from you within the 7 or 10 days, or you reject my request to see the records, I'm going to file a complaint with the state regulatory agency or something like that. And I think those are pretty easy complaints to get resolved, because it's just, like I said, it's a clear right. And if you've reduced your demand to writing, they're cornered. And if any refusal at that point is going to be bad news for them. On the other hand, this brings up another issue of the facility is resistant to the most basic requests to see medical records. They should, ideally, they would say, oh yes, let us get you the records. And then let's talk about them after you've had a chance to review them, so that we can discuss any concerns that you might have. Or prior to your reviewing the records, tell us what your concerns are so we can start to address them right away. That's the reaction you want. Anything less than that is a concern. If they're avoiding providing the records at all, that is a major red flag that they either don't have their act together to comply with a simple request, or they're being evasive because they don't want the family member looking into the medications and making any adjustments. That's probably not a great care partner, and it's either an opportunity to work with them to get them up to speed on good provision of care, or maybe you're starting to look for a new place to go.
Right. That's a really good point. And so, earlier you were talking about how, often it's better to try to stay within a facility, just because, and I completely agree with that. My own grandmother was transferred to multiple facilities, and you can see it again, going back to the fact that, this is someone's home. Every time someone moves facilities, it can be a little bit, it can be more confusing for them, and they have less of an idea of their own bearings. But, in light of that, I just wanted to bring up transfer discharge concerns and the rights that residents have. We know a resident can't be discharged, very easily to start with. They can't be discharged for not consenting to antipsychotic medications. However, a lot of families, and I think, Kathy's family was one of them, that was very afraid if they said no to the medication, that, her mom or, their loved ones will be thrown out of facilities. We know that, facilities can try to get around some transfer discharge protections by claiming that they can't meet the resident's needs, that the resident might be a danger to someone, if they've swatted at a staff member or something like that. So can you just talk a little bit about how families who are acting on behalf of their loved ones can handle situations where they're threatened with discharge, or they're afraid that that's what's coming?
Yeah, to start with, I know this is easy for me to say. I've been doing this a long time, and I feel comfortable with my level of expertise and things like that. It's really something important to impress on consumers and their family members, is that a discharge notice doesn't mean that the sky has fallen. It means a lot of things, and it's definitely something serious. But in a lot of cases, I tell people we're inviting the discharge notice, because now we've got them trying in their best way to reduce their concerns about providing care in the future into writing. And normally there's a whole host of rights that go along with the discharge notice, so that the resident just doesn't have to pack up their stuff and go that day. There's usually a lot of advance time, and there's appeal rights, and the facilities oftentimes get the discharge notices wrong. So if you file a complaint, they're found defective and they have to start over again. And a lot of times they're not willing to start over again. To me, the threat of discharge is often used And it's sometimes, I don't even think it's stated out loud, but it's used to get residents and family members to toe a line.
Right. Yes.
And that's a problem. And I think a lot of times the discharge threat is completely idle. That the facility they could go forward, they could do a discharge notice, but they're just not going to have the legitimacy to actually legally carry through with the discharge. So don't panic if you get a discharge notice, and don't let the threat of a discharge notice steer you away from what is doing the right thing for your family members or for your care advocacy. Once you get a discharge notice, you can deal with it. There's ombudsman programs, there's resources online, there's citizen advocacy groups, consumer voice. All of us can help people deal with the legal side of the discharge notice. But to me, a discharge notice is a admission of failure on the part of the care provider. More often than not, it's an admission of failure, and that's important to know. I think that it's an opportunity to try to build up a new style of care, and it's also sort of a way for the consumer to tell the facility that you failed. You said that you were going to provide care, and now you're trying to get out of it, and that might be a breach of contract situation. It actually might give the resident and the family member some legal leverage to pursue avenues that they might not have been able to before.
I think that's a really good way of looking at it, because I know, when I think of someone, as Kathy's explaining her story, I don't think that's the way most people, immediately think of discharge notices. I think you internalize it. Someone's telling you that your relative isn't a good fit, that they don't fit in where they are, that and you're right, it's not even always the actual threat, it's just sort of the underlying idea that this might be what happens. A lot of people feel like that's their failure or their relative's failure. They don't look at it from the perspective of the fact that this facility has certain obligations and they failed to meet them. So I think that's an empowering way for families to look at the situation.
Yeah, there's two things I want people to know more than anything. One is, this is an industry where consumer dissatisfaction is common. All right, so there is a lot of poor care that's out there, or less than satisfying care. So don't feel like you've done anything wrong if you're in a facility or your loved one's in a facility where the care is not that great. The second thing I want people to feel is empowered. I want them to know that you have more power legally with a whole host of statutory and regulatory rights, but also as a consumer and with market power and with the kind of love that maybe the facility staff are lacking to bring into the mix, you've got a lot of power.
Yeah, I think that is important for families to recognize, because I think you feel, as I think you can probably tell listening to Kathy, they felt the opposite of that. They felt powerless. They felt like they didn't know if they had the right to push back, what they could do, what they should do. And I think, again, if you're told, if there's a family listening to this now and you've been told that your relative is, a lot of facilities will use the word difficult. You feel like that's just you, like this is happening just to you, to your family member. But what what her experience was, what her family's experience was, it is common. And as you said, there are a lot of people who are not happy with the treatment and how people are being received by the staff. So I think that's really important. Yeah,
Labeling a resident difficult or not a good fit is sad and frustrating to me. And it should be sad and frustrating to care providers to hear that. From my perspective, as a caregiver, you want to probably do the greatest good for the greatest number of people. And if someone is, quote, difficult, to me, that's an opportunity to make their lives better. There's probably some simple solutions that just haven't been applied yet. So as a caregiver, I want the challenging resident because I feel like I can provide the greatest good to that particular person and that particular family. And if you're in a facility where the culture is not that, where the culture is difficult people need to be excluded and taken out, then I think you either got to make a stand and try to improve things in that facility or get the hell out.
Yeah. So Something else that Kathy talked about that I think is important, maybe more important right now, is, she talked about her mom being sent to a psych ward, as she said, to be stabilized. And she noted that the doctor suggested her mom might be bipolar, a diagnosis that Kathy, acknowledged is not something that happens to you in your 70s. But we've recently heard more of this, residents being diagnosed for the first time in their 80s with schizophrenia after they've gotten to facilities. We know those numbers have gone up even more during the pandemic. So we also know that those are not accurate diagnoses. Like, people are not becoming schizophrenic in their 80s. But what can a family do? What can someone like Kathy do if a doctor says to her, we think your mom is bipolar, or we think your mom has schizophrenia? If a family gets that type of diagnosis, what questions should they ask, and who should they talk to?
Well, I think they should certainly be skeptical of something like that. I think that families should be skeptical of medicalizing anything related to dementia, because that's sort of a fallback for nurses and doctors to do, and it's just really an access point for them to get into medicines. When Kathy's mother was taken to a psych ward for stabilization, what it probably meant was for her to be chemically restrained and
Right.
subdued, not stabilized, but subdued, with the use of chemical restraints. And in psychiatric hospitals, they're probably more comfortable and have less regulatory challenges to chemically restraining patients. So then send them to the hospital, get them on a bunch of meds so that they're lying down, sleeping 20 hours a day and drooling on themselves, and then bring them back and keep them on those same meds. Again, if a physician or nurse brings up a potential diagnosis, by all means, hear them out. They may have some valid points and some things that they're some light to shed on the situation. I think the family members and residents should be very skeptical. What I find in these situations with the medicalization of diagnoses and symptoms that are really just somebody expressing discomfort or pain is the healthcare providers are really making their lives easier. Their goal is to make their own lives easier rather than making the resident's life better. So you have to be very, very careful. And a lot of people ascribe, high value to physicians, and they're sort of the experts, and they're always concerned about patient care. But physicians are fallible like anybody else. And a lot of times the way that they're fallible is that they want to please the people who seek their help. And a lot of times the people who seek their help are not the patients. It's the care providers around the patients. So the physicians want to improve the lives of the people that reach out to them. And in a lot of those situations, it's the care staff. And the way to make the care staff's lives easier is to make the resident much more pliable and mute. And oftentimes that's medication. So got to be very careful with this stuff. Very, very careful. Again, hear them out, but do your homework and don't agree to anything unless you've done a lot of homework and you feel like it's the right thing to do.
Right. And I think something you mentioned just kind of briefly is, these residents often, they're in pain, and I think this is something that is often overlooked, and especially in a patient with dementia who doesn't necessarily have the words or the ability to express themselves in the way that you or I could. A lot of times some of the screaming or shouting or, as I believe it was termed in Kathy's facility, these behaviors, are coming from a place of pain, whether it's a UTI or it is a bed sore or it's something else that, we might not be aware of. I don't know that people always look at the residents, like as you described, some of the doctors who might have conflicting, interests in terms of who they're working with and for. Some of these residents are in a lot of pain, before, and that's why they're behaving in the way that they are. And that explains a lot of their actions. So it's important to remember that there might be other underlying causes.
Yeah, there's a relatively famous study where they looked at the pain medications given to people after hip surgery, and the folks that had dementia received half as much pain medication as the people without dementia.
Wow.
Following hip surgery. And is it because people with dementia don't feel pain? Absolutely not. They feel pain just the same way as anybody without dementia feels pain. The difference was they weren't able to say, this hurts. With
Right.
with those particular words, the magic words of I'm in pain and my pain level is 8 out of 10. Instead, they would quote act out. They would
Right.
yell or be resistant to getting their clothes changed because it hurt, and they were doing their best to tell people that, but they weren't being heard. So underdiagnosis of pain is a big problem with folks with dementia. But I also want to mention one other thing, and this sort of, I think, really shifts the paradigm in thinking in terms of dementia care and this whole medicalization thing, which is the way we provide care for babies. Everybody knows, just sort of naturally, intuitively, that when a baby cries or seems upset, it's not because they have a disease that needs medication. It's because they have an unmet need. And everybody knows this. And we go through checklists in our heads. Are they hungry? Do they need a diaper change? Are they cold? Maybe they have, they're teething and their gums hurt. Could be so many things. And so many times for babies, it's just they need attention. They need to be picked up
Right.
and reassured and loved. And while physical pain is a big problem in dementia care, psychic pain and lack of human connection is also a significant problem. And that could be the cause for a lot of these quote behavioral challenges. And it's just as simple as creating some human connection to take care of a lot of that.
Yeah. No, that's a really, really good point. It's the same lack of ability to communicate in both instances.
Right.
So something that, we talked about a little bit earlier, but, Kathy says towards the end with her in her conversation is that she wishes she'd had the language to push back. She said, as we discussed before, that she does, she acknowledged that, you're an expert on your own loved one. But, I think it's important for families to have to know if there are words, what they can actually say, what they can do, so that they can try to do what you described earlier, is work with the facility as a partnership, because that can be very difficult, as you have, noted yourself. Sometimes facilities aren't that amenable, but in general, I think having language, knowing sort of what they can say and what they should be saying, is important for families, even families who might be listening right now, because there is this assumption, I think, that some people do have going in, as we discussed before, that the facility is right. You hear a facility say this to you, that your loved one needs this medication, that this is happening, that they can't control this person, that they might not be able to fit into this facility. And I think for a lot of families, if they don't have the words to use or know what arguments to make, their initial assumption is going to be that, that's right. I don't have the space to push back. And I think in Kathy's situation, that's a little bit of what was happening. And so I know, we have resources for families, but I'm just wondering if you have any thoughts or specific suggestions for families.
Yeah, this is a great thing to talk about. And now that I think about it, so many times when I'm talking to callers who are upset about some aspect of long-term care, and I encourage them to write a letter,
Right.
and I'll say, your letter can say A, B, and C, and I can tell they're furiously writing down every word that I'm saying, and they say, oh, you're saying it. Can you repeat that? The words are so good for my problem, and I wouldn't be able to put it in quite this way. So language I think it is super important. And I mean, the long story short on language is to just go on the internet and find resources that are in your area. I know Consumer Voice has a lot of resources. My organization, California Advocates for Nursing Reform, has about 75 fact sheets on different aspects of long-term care to give people
Right.
power and to give them the language to use. But two things on the language bit. One, on the dementia care stuff, I strongly encourage people to read Dementia Beyond Drugs. Dementia Beyond Drugging, I think is what it's called, by Dr. Al Power. It's a great book. It's not that long. It's like $9.95 on Amazon, and gives people a lot of perspective on what good dementia care ought to be like, and tons of good language. And I also think an actual phrase that every consumer and family member should know is care plan. Um,
Yes.
on the nursing home side, federal law requires an extensive iterative care plan that's constantly being evaluated and implemented, and that is partially authored by, hopefully, by the resident and their family. And then in assisted living, oftentimes care plans are also foundational, even if they're not quite so legally required in some states. But family members should definitely be pushing the care plan. And the language of the care plan is really the language of the resident's needs and how they're going to be provided for. And on that, I think family members, as you mentioned before, especially with Kathy, on that, family members are experts and they know the language of what their loved one needs and what their loved one prefers and doesn't prefer. So definitely want to talk up the care plan process.
Yeah, I think that's important. And I think, what you said at the very beginning, having the right to good care, that residents have the right to this quality person-centered care, every resident in every facility, and I think having that in mind going in is maybe helpful, because I think that gets lost very quickly when you start, hearing this kind of pushback from facilities about your loved one.
Yeah, it gets back to don't be afraid to be demanding.
Right.
And another thing is, there's no problem at all with asking the staff of the facility to say, can you explain this to me? I'm not sure about it, or it feels wrong to me. So can you explain uh, why you're doing things this way? And let me tell you my reservations, and hopefully we can come to a meeting of the minds. Don't be afraid to say, I don't know, and I would like for you to explain it to me. They should be able to explain it to you. I bet sometimes they're not going to be able to, and then you've identified a real problem.
Yeah, I think that makes a lot of sense. So, do you have any final thoughts or words to share before we
Yeah,
end
one
today?
one last thing I wanted to mention that I wanted to talk about before. Um, you know, I think for the most part, the caregivers are always trying to do the very best that they can. But the concern is that sometimes they don't know the best way to provide care. And that's where the family members and the consumers can really come in and help push the staff into what's the best for this particular resident. And what we like to say is when people know better, they tend to do better. So part of our job, and it seems a little odd that we would have to educate the professionals, but um, again, this industry does leave a lot of dissatisfaction with folks. So this is an opportunity to educate them, um, to provide better care for everybody, but in particular, you're the expert on what you or your loved one needs, so educate them on that. And so I don't want to impugn caregivers. I know that they're not trying to actively hurt people. It's just a lot of times they don't know how to do things better, and it's our role to try to work with them to get there.
Well, thank you so much for joining us today. We really appreciate it.
All right, you're welcome. And I encourage anybody, with significant concerns or problems, reach out to Consumer Voice, reach out to CANHR. We are here for you. The reason we exist is to take calls and emails and concerns about long-term care and try to help people through it.
Thanks a lot.
You're welcome.
Pursuing Quality Long-Term Care is a program of the Avoiding Drugs as Chemical Restraints Consumer Education Campaign, a partnership of the National Consumer Voice for Quality Long-Term Care and AARP Foundation. Make sure to visit our website, theconsumervoice.org/pursuingquality, where you can share your story with us, subscribe to the podcast, and find more information about the campaign. If you enjoy the podcast, please rate, review, and subscribe. Thank you for listening, and we'll see you next episode.